Welcome back to another Clinical Conversations with Reza. I say it as if we've had 100 of these, Dr. Arpan Patel, but we've only had one. You are our second guest. And is it okay if I refer to you as Arpan?
Yes, for sure. An honor to be here. Thanks for having me.
And for those of you that don't know, Arpan, myself, and Dr. Essien work out every Monday at the VA gym. So if you're around and want to exercise, get in touch with us. Before we get started on today's topic of cirrhosis, give us your one-liner.
No, yeah, it's exciting to be here. I've been on faculty here actually at the VA for, I'd say it's going on my fifth year. So I'm a liver transplant specialist and liver specialist, which we call hepatologists. And I actually do a lot of research too. So I do health services research in basically patient-centered care, so palliative care and integrating addiction medicine and the care of patients with liver disease. So it's kind of cool to be able to both, treat these patients and also research them at the same time. And also a Southern California native, and I've been in LA for almost 10 years. So I'm just excited to be here.
And what do you enjoy doing outside of work, Arpan?
I would say that I enjoy going out, fine dining, running, hiking, working out on Mondays. I guess that's technically considered in at work, but it doesn't feel like work.
I
So
think that's going to be your toughest question of this session.
I know. I try to keep myself busy.
How did you fall in love with the liver?
Like I actually, when I was in third year of medical school, I had a really strong mentor who actually was our course master for our pathology, and he was a hepatologist. And he actually somehow got six people in my med school class to do hepatology. He's just very smart. His name is Dr. Heron, very smart. Just was so good with patients, and I just wanted to be just like him. And I knew, again, from third year medical school, I wanted to be a hepatologist, and it just kind of grew from there.
Can I ask you what specifically made him so good with patients? Like, what do you remember from that period?
I think it's something I try to do a lot with my patients to the best I can, but he was really good at sitting down and explaining to them why they had liver disease and why they had cirrhosis. I think it's an important part of caring for patients, and I just felt like he gave so much attention to them, and that's something that I think our patients need. And so that's something that stuck with me a lot. And he was just really good at teaching, which is something you're really good at doing. So I'm trying
Hey,
to think.
listen, flattery is not going to make my questions softer, okay?
Yeah. No, but a good teacher, good educator, really good with patients.
I love that. And Arpan, today's goal is to give the audience practical tips in both diagnosis and therapies of cirrhosis and give us up-to-date knowledge. And what I encourage the audience to do is to write down any questions you may have and put it in the Q&A. We will ask Arpan any question. Our goal is for you to leave this session with 3 new knowledge nuggets that's going to impact the way you approach patients with cirrhosis. Why should they care about cirrhosis, Arpan?
Yeah, I get asked this question a lot. I think, I sort of see things from a public health lens in addition to being a clinician. And something we know both from clinical practice as well as the numbers is just that there's so much liver disease going around. It's increased by several fold over the past decade. There's also a shrinking amount of hepatologists being able to treat the patients. So now more than ever, it's become kind of a team sport, being able to work with generalists, hepatologists, gastroenterologists, everyone together. And they're super complicated. And we know that. And I think part of sessions like these and, being able to round with us, going to our clinics is just really having this sort of bidirectional communication about it. And so I'm really passionate about that.
You know, oftentimes when you read a good book, watch a good movie, they take you right to the scene of the crime. Like someone gets murdered, and you're like, how did that person or why did they get murdered? I want you to share 3 practical points you wish everyone in the audience, regardless of whether they're a hepatologist, a cardiologist, an internist, a clinic doctor, an inpatient doctor. What are 3 practical tips you want them to be aware of?
Maybe I think it's sort of a combination of like suggestions on things to work on, but and also in addition to things that you should know about. I think the first is that we have a lot of stigma for patients with liver disease. We use a lot of language that's stigmatizing. The way we talk to our colleagues about patients with liver disease is very stigmatizing, and it actually we know now from national guidelines and consensus statements that that's really contributing to a lot of problems with care. So, saying even like people talking to each other like a liver bomb as a patient, or saying it's a cirrhotic patient instead of a patient with cirrhosis, or calling a patient an alcoholic instead of someone with alcohol use disorder. These seem like wokeisms, or things that are the small things, but they are big things. I have a lot of patients tell me a lot in clinic that they feel like they were ignored, or people use language to them that they didn't want across multiple settings before getting to me. So I think one big takeaway is just recognize how stigmatized this population is. It's something I tried to do. I think a lot of us in the hepatology community are now realizing something we could do better. And the other thing I think is just a practical tip, which I think all of us can be better at, is when you were talking about one-liners, it reminded me of like how we can all work on our one-liners for patients with cirrhosis better. So for instance, and it gives you a lot of information about how much depth someone has about seeing these patients. So for instance, if you say someone has cirrhosis of the liver, there's a big difference between that and saying someone has decompensated cirrhosis from hepatitis C, complicated by ascites and variceal hemorrhage with a MELD sodium score of 30. One gave me very little information. One gave me a lot of information that I now exactly know what's happening to the patient. So I think that one thing we can all do across all fields of medicine, I think we can always be more specific when we think about and talk about patients, but the specificity is particularly important, I think, in cirrhosis.
Very, very helpful. And so, Arpan, what I'd like to do now is share a case, and the case will start in the clinic because I want to make sure that we have good teaching points for all practitioners, and then we'll end up in the hospital ward. And this is a story of Miss C, who's 53 years old. She's a mother of two adorable kids and a former coffee shop owner who over the past several weeks has developed abdominal swelling and yellowing of her skin. She presents to clinic because of these symptoms. She has a history of hypertension, obesity, and hyperlipidemia. She's also been feeling more lethargic over the past couple of weeks, but no other symptoms. Her vital signs are normal. She doesn't have asterixis. And as the PMD, we're concerned, could she have new cirrhosis that's decompensated? So what I'd like to do now is step back for a second. And if you can tell us how helpful is the history and exam for cirrhosis, and is it appropriate to consider it in this scenario?
Yeah, I think that's a really great question. A pretty common one, I think, that you're mentioning is someone having a new decompensation when they come in. I think that by and large, and our community still largely believes that cirrhosis is a clinical diagnosis. So the history and physical is actually tantamount. And there's sort of ways you can think about it, like very discreetly in terms of how cirrhosis is, and there's sort of broad pictures. And I think, generally speaking, for me, when I see a patient, I'm thinking about complications of portal hypertension, so if they have ascites, hepatic encephalopathy, signs and symptoms on exam of both of those things. So symptoms of hepatic encephalopathy could be lethargy, fatigue, while, physical exam findings could be asterixis. Same with ascites, abdominal swelling versus seeing for yourself ascites on exam. And also, on physical exam, thinking about some complications related to liver disease that could be due to reduced function. So, if someone has jaundice, looking to see if they're icteric, looking underneath the tongue, also in the conjunctiva, and then looking for those really important physical exam findings that actually we know are associated with the high probability of having cirrhosis. So some of those are spider telangiectasias, which you commonly can find on the chest and many other parts of the body, palmar erythema, Terry's nails, actually, the loss of the lunula of the nails. So these are associated with a really high probability of having cirrhosis if you find them. If you don't find them, it doesn't mean you don't have cirrhosis, though. So they're very specific findings. They're just not very sensitive. Um, and so I think that may answer your question about like, what you look for in an exam. You're obviously also looking for an etiology if you suspect cirrhosis. So this patient you described with metabolic syndrome has a high chance of potentially having what we call now MASLD, which is the formerly fatty liver disease. So it's kind of a combination of the complaints you were talking about, physical exam findings, and then also looking for an etiology.
I think that's epic. So the way you think about cirrhosis is one, portal hypertension, and the other is a decreased function of the liver. For the portal hypertension, you just think of complications of that from abdominal swelling due to ascites, varices. For the liver function, you think about elevation in states of estrogen leading to spiders, palmar. But in general, a patient may look totally normal, and then you get a lab finding, you're like, oh, could they have cirrhosis? Is that an accurate summary of that?
Yeah, totally. So if all of those things, right, we were talking about, if they have nothing on physical exam finding, if they don't have a distinct etiology, that platelet count is less than 160. We know that that's associated with a much higher risk of having cirrhosis. And we know that you can have perfectly normal liver enzymes and still have cirrhosis. So I think that the classic teaching has always been look for these physical exam findings, but it doesn't mean that you can't have cirrhosis with all those things being normal. And I think that's something we're recognizing more, that a lot of people are probably undiagnosed, and the only telltale sign might be, these subtle changes in what I call actual liver function tests, which are platelet count, INR, and albumin. So those are in my mind, the real liver function test is when you actually look at what actually leads to impairments in liver function.
Love it. So the other tests, that LFTs that we know, you probably call liver chemistry tests, maybe?
Yeah, I call them liver chemistry, liver enzymes. It's one of my pet peeves is when people call those like AST, ALT, and alk phos liver function tests. I think even some hepatologists do, but they don't really tell you liver function.
In Arpan, why the change in name? Like, why are they making it so difficult for us? Why go from NASH to MASLD? And for the audience to know, on my script, Arpan corrected me like 3 times on this terminology. I was calling it MAFLD. I was combining the two terms. Why the change?
Yeah, the change happened for a lot of reasons, so basically this whole spectrum of fat in the liver there's lots of causes. There's alcohol, there's metabolic syndrome, there's even stuff related to drugs, medications causing it. So part of it was just being specific. So, MASLD stands for metabolic dysfunction associated steatotic liver disease. So part of it was separating that from alcohol associated liver disease, and then steatotic liver disease that's not related to it. Some part of it was practical, but when they constructed the new definition, they actually included the perspectives of patients and caregivers. And it seems again silly, but at the outright, but they felt that the fatty term was stigmatizing and wasn't helpful. And so I think making it more grounded scientifically was something that was important to patients and families. And some of us are struggling with that a little bit in terms of like really explaining to patients what steatosis is. They may not understand it, but I think it pushes us to educate people more. So I think it's all moving in overall positive direction.
That's actually something I admire so much about you and what I've learned from you over the last couple of years in our friendship, how important terms are to those we care for and how we regard those individuals. Arpan, so this primary care doctor has MIS-C, some abdominal swelling, some yellowing of the skin. What is the threshold for the primary care doctor to send this patient to the ED versus sending labs and then following up those labs versus making a referral to the liver clinic? Like, how would you guide us?
Yeah, I think it's a really good question. I think the way I would answer that first, maybe a little bit of a cop out, it depends on what your type of health system is and how you're set up. Really, if there's one hepatologist caring for 2,000 people, you can't send everyone to hepatology. And then if the ED is like a 3-hour wait, you can't send everyone to the ED. So that's one thing to keep in mind. But I think the major question, right, if you see someone with a new decompensation, the reason to send them to the ER is if you are worried about undiagnosed SBP or sepsis or something that like a cause of a new decompensation that can't wait. So, if someone has a total bit like a MELD score of like 21 or above, and that they were normal 2 weeks ago. Like you gotta, there's something new is happening fast. Or if they, come in with, looking sepsisy, or even come in with new ascites and never been tapped. I worry sometimes if they look unwell that you have to send them to the ER. So I think some of it is a clinical judgment call. I mean, the types of cases where I don't necessarily send them to the ER is if this is not their first decompensation, if they're coming in, their ascites is not well controlled, but they can manage and they're still able to get around and breathe okay, that person can be scheduled for an outpatient paracentesis. So some of it has to do with like distress, I would say, and how new the presentation is, if that makes sense.
That makes a lot of sense. Now, let's say it's a patient where you get imaging for some reason and the imaging suggests cirrhosis, but you didn't even have that clinical suspicion. And now you want to refer them to the liver clinic. One, can you just comment on how often people get a radiographic diagnosis of cirrhosis? But two, when we make that referral to liver clinic, what are the tests that you want us to send? And
Oh.
absolutely everyone.
Yeah, that's a really good question. And so first off, the diagnosis that comes from incidental imaging is really common. That's probably a large portion of I review all referrals for hepatology clinic at the VA, and that's like a huge cause of referrals is just the imaging. So this is a very pertinent question. Things that you should always consider getting is ensuring that the patients have a full set of liver enzymes, including an INR, a direct bilirubin, and a CBC, just to give us a full sense of the liver chemistries and the liver function tests, right? As we were talking about, making sure to send a basic workup for causes of liver disease. So all the viral hepatitis serologies, Hep B, Hep C. Hep A antibody is helpful because you have to immunize someone if they're not immunized for Hep A, if they have cirrhosis. And then also I always get iron studies on every patient who's diagnosed with cirrhosis just to check for iron overload. And those are the basic things. I don't always send an autoimmune workup or workup for Wilson's disease or alpha-1 antitrypsin because that sort of is more dependent on their history. And I don't necessarily expect all people just, having all that information at hand when they're just reviewing ultrasound or CT. I think also like a clinical assessment of decompensation is pretty critical. So, if the person has ascites on that imaging study, or if they clinically had it, or they complained and you have a sensitivity of the fact that they bled recently, or they had confusion, like those are things that I want to hear in the referral so that I can see this person sooner, as well as if their total bilirubin is up. So I think there's like things you should get, but also things you should let us know so that we can see someone sooner, if that makes sense.
That makes a lot of sense. And can you make like a radiographic diagnosis of cirrhosis, specifically ultrasound or CT? Like, or is it oftentimes, yeah, I would love for you to comment on that.
Yeah, it's another great question. So I think like, again, our field has mostly relied on this idea of clinical diagnosis, so putting the pictures all together. And I will say that many times you could make a diagnosis of cirrhosis just with physical exam if they have a finding, nodular liver on ultrasound and a platelet count being low. I think we are moving towards more objectivity with how we assess cirrhosis now, depending on your facility. So FibroScans have been kind of a boon to us. So it's elastography, that's the method, ultrasound elastography, and allows us to approximate the amount of scar tissue in the liver that patients have fibrosis, going from stage 1 to stage 4. So I think we're moving towards creating more objective assessments of whether someone has advanced fibrosis as an adjunct. So for me in my practice, because FibroScan's so available, I just send a FibroScan for everyone I suspect to have cirrhosis. I don't expect a PCP to do that, or primary care team or hospital medicine team to do it. I have a heightened reason to send it in particular for people that I'm worried about alternative etiologies to cirrhosis. So if they have these conditions called nodular regenerative hyperplasia, which can look like cirrhosis on imaging but isn't cirrhosis, or if they have pseudocirrhosis, which is metastatic cancer looking like cirrhosis on imaging in particular, then I not only send them for a FibroScan, but I, in some clinical contexts, might even consider biopsying them. So, I don't know if that's a lot of stuff at once, but I hope that answers your question.
No, I love it. And I think like we should maybe stick and talk about the fiber scan for a second. What exactly is that test? Can you explain it so we understand how does that test assess fibrosis and what are the limitations of that test?
Yeah, so it's called elastography. So this is a type of test where, vibrations are sent through the skin to the liver, and this allows us to approximate two things. So it gives us a sense of how much pressure is being transmitted back from the liver, and that the higher kilopascals, which is, remember from chemistry, it's a physics that's a measure of pressure, the higher amount of kilopascals indicates that there's more fibrosis because fibrosis makes your liver stiffer. That elastography gives us that information about amounts of fibrosis, which correlate to stages of fibrosis in what pathologically. So for instance, and there are different intervals of kilopascals and cutoffs for different disease states like alcohol and MASLD and hepatitis C. So a lot of times what I do is when I have a fiber scan in clinic and I teach the residents or trainees, I sort of show them this nomogram we have of different kilopascal cutoffs and stages of fibrosis. The other information it tells us is fat quantification. So it's called the CAP or controlled attenuated parameter, and it also gives us some estimation about the amount of fat in the liver graded from S1 to S3, which are steatosis grades, S1 to S3.
Wow, that's really helpful. Is there anything we should know in terms of false positives or negatives with this?
Yeah, so things that and this is not uniformly implemented and there aren't any kind of standardized guidelines, but generally speaking, for people who have very large, like high BMIs, like 35, 40, that can interfere with our ability to accurately get a good good kilopascal quantification on patients. The other thing is if people have recent drinking, which is not an uncommon issue in some certain patients, that can overestimate the kilopascals. So, and the other thing is that it could also just be inaccurate. So it's not a completely accurate study. And in certain cases where there's a sort of a discrepancy between what we're seeing on the fiber scan and their clinical picture, like if they have splenomegaly and a platelet count of 100, but they're F0, F1, then I go for another study, like an MR elastography, which is a magnetic resonance elastography, which is basically, a simple way of putting it is a fiber scan, but it's an MRI.
Wow. That's very interesting. If before we get to biopsy, like I imagine decades prior, biopsy was probably more commonly done before the advent of these newer studies. Before we talk about who do you still biopsy to confirm cirrhosis, the earlier you diagnose the fibrosis, it seems like cirrhosis is a spectrum, huh? From F1 to F4. Is that fair to say? The earlier you diagnose, it would make sense to me, the earlier you can reverse. And so diagnosing patients with possible fibrosis is of paramount importance.
Yes, and so we're recognizing that in addition to diagnosing cirrhosis, like you mentioned, there's a personalization, right, that we get from any liver disease, knowing how much fibrosis you have, like knowing if you're F2 or F3 for something. It's like, I don't want to get to cirrhosis. So like, I want to be able to control my risk factors so I don't get to cirrhosis. So the recommendation actually at this point is that many different health systems and clinical practices have been using something called a FIB-4 score to non-invasively estimate whether a person might be at risk of having F3, F4. So it's a simple blood test. Well, it's a test that includes age, AST, ALT, and platelet count, and allows you to basically risk stratify if someone might have cirrhosis or if they're at a risk of not having any, basically having F0, F1. So the cutoff is 1.3. If someone has a FIB-4 or 1.4, 1.3 to 1.4, if it's less than 1.4, and you calculate it, that means that they likely have F0, F1 disease. And conversely, if someone has 3.25 or higher, they almost certainly may have liver disease, like F3, F4. And people in the middle are recommended to all get fiber scans.
I see. So I guess is F4 necessary for the diagnosis of cirrhosis? Is like F1 not considered cirrhosis?
No, 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 no. Yeah. If you're F1, F0, that means that you have basically stage 1 fibrosis, which is, I tell patients you're like a fourth of the way to cirrhosis.
Wow. And it seems that fibrosis is the end result of various pathologic problems, Hep C, alcohol, fat. Does it matter what's driving the fibrosis in terms of reversibility of, like, let's say you're F2 or F3 from Hep C versus alcohol? Is the reversibility any different with appropriate treatment or
It's kind of a
cessation?
million-dollar question. I think the truth is that we probably don't have the best amount of data to know which patients always reverse their fibrosis and which people don't. And part of it is because, a good example is hepatitis C. So hepatitis C is now curable. We have many, many patients who got treated at the VA and other health systems. And we often get fiber scans for these patients, and somehow their fibrosis is getting worse even after treatment for hepatitis C. So it turns out that a lot of people probably had some MASLD at baseline that wasn't getting addressed while they had hepatitis C, or they had alcohol-associated liver disease. So you can imagine from like just a sheer information standpoint, so many people have many different causes of liver disease that are in flux. So we don't always know if that regression is because we treated the big cause, or it's not regressing because they have other causes. But generally speaking, I think most of us believe that by treating the underlying causes, identifying as many causes as you can and treating them will lead to some fibrosis regression. Interestingly, there's a whole area of science that's dedicated to discovering novel agents to address fibrosis, which haven't necessarily are not at market yet. They're still in very early, trial phases and development phases, but the real problem is the fibrosis. So if you eliminate the cause, we do expect some people to regress.
I love that. And the liver is just one of the organs affected by these conditions. So even if the liver is end stage disease, you would still want to treat Hep C because it can affect multiple other organs. You still would want to say stop drinking alcohol. It can affect multiple organs. Since you talked about it for the MASLD, I'm not going to even try to name the acronym right now, but for the MASLD, like, what is the updates and treatment options?
So I think overall, we know that for a very long time, there weren't any medications that were available to treat MASLD. The newest one that there now finally is a medication that's FDA approved. It's called resmetirom. There was recently a New England Journal article about it. It's also called, there's Resdifra is the other name for it. So I have to be perfectly honest that I'm not completely familiar, remember all of the language around the clinical trial and exactly what the mechanism of action for is, but that's the first treatment that we have for MASLD that actually is associated with a reduction in fibrosis, which is like an important endpoint. But overall, from a therapeutic standpoint, we also have medications that help support weight loss. So things like Ozempic, and those have been associated with dramatic loss, reductions in weight. They've also been associated with reductions in steatosis and some fibrosis too. So we are getting a larger armamentarium of medications. But generally speaking, the name of the game is weight loss. And so, any sort of interventions that can promote weight loss, we recommend a 10% reduction in weight for people who have F3, F4, which is stage 3, stage 4 fibrosis or cirrhosis, if they have MASLD as their underlying cause.
Well, this reminds me, when we're in the gym and I'm just asking you questions, it's epic. You're adding so much to my knowledge, and I'm sure to the audience's knowledge. I just want to summarize where we are before we continue. And I also want to encourage the audience to ask questions in the chat. If you're in the conference room, come to my office and show your face and ask your question. So far you said, really, cirrhosis remains like a clinic, the clinical diagnosis is very important. And the findings increase the post-test probability, spider angiomata, pulmonary erythema, teary nails. But the lack of any findings doesn't necessarily negate the possibility of cirrhosis. And the way you thought about it was portal hypertension and its consequences, and the liver not functioning well and its consequences. And I just want to give a shout out to today's trainees who can do POCUS and can easily answer the question in clinic, does the patient have ascites or not? Then it seems like you alluded to the top three causes being alcohol, the metabolic associated liver dysfunction, are you proud of me? And hepatitis C as the main culprits. And you said that if we are concerned about this, but the patient's not decompensated, we make a referral to liver clinic. We should send the liver enzymes because really the liver functions, the platelet, the INR, the albumin. We should send the hep serologies and iron studies in the chance that they might have hemochromatosis, but we don't need to go crazy with like Wilson's, autoimmune hepatitis, and all the other studies. And then what was really informative for me is like this power of the elastography, which is looking at how much of these waves is being reflected back to tell you what the fibrosis is. While it's not perfect in those who are very overweight, it's a very good test. And a tool that you can tell your patient, look, you're at F2, you're not the threshold yet for cirrhosis. We need to make changes to your diet. And nowadays, with the new therapies, it's a really exciting time, I think, to treat obesity. Before I ask you my next question, anything I missed that you want to further highlight?
Yeah, I just want to say that, like, so we also often think about a lot of this from a North American lens, but globally speaking, the most common cause of liver disease is hepatitis B. And so, I think one interesting aspect of all this is just how specialized hepatitis B treatment is. Like, you feel like you have to go to a hepatologist, but globally it's like there was stuff talking about at least 1 billion people with hepatitis B in the world, So how, just even the challenge of thinking about that and treating it globally is such a huge thing, that another reason why we should all care for liver disease.
Wow, thank you. Arpan, who do you do a liver biopsy? And like, let's say you have a patient, you have the thrombocytopenia, you have the elastography showing F3, F4, like when do you say I need to do a liver biopsy?
Yeah. Also, we have a question, so I didn't know if should I answer that.
Oh my gosh, their question is more important than my question. So
yeah, I'm definitely happy to answer it, but I just
yeah, please answer their question first, and then we can do my question.
Okay. Someone raised their hand.
Oh, okay. Oh, I see. Here we go. Allowed to talk. Please unmute yourself in the VA.
Oh, fantastic. Your chat is disabled.
Oh, okay. Well, in order to allow questions to be asked, we got to make sure the chat is enabled. We will work on that, but maybe in the meantime, people can raise their hands to ask questions.
I was going to ask one question. Why is it that a patient could have normal liver tests, liver function tests, liver synthetic function, and still have cirrhosis? Why,
Yeah, it's a good question. I think, maybe just to add some more specificity to it is that people can have normal transaminases and alk phos, and sometimes the only sign is that they have like a platelet count that's low. So what I sort of mean to say is that these liver function tests that I'm talking about, like albumin, INR, and platelet, ended up being more of a common indicator sometimes that patients have cirrhosis than what we traditionally view as liver chemistries like AST, ALT, and alk phos. So typically speaking, what I mean to say is that sometimes those liver chemistries are normal, but they have something abnormal from a functional standpoint. That answers your question.
Thank you for that question. So everyone, just please raise your hand if you have a question, and then we'll unmute you. So Arpan, who are we doing biopsies in these days?
Yeah, so I think the major questions I always ask myself when I consider a liver biopsy is this going to change management if I do the biopsy? Well, the first question is, am I thinking of at least one other thing that can cause this liver disease or this clinical situation? It's not just one thing. If I'm really certain that it's one thing, I'm not going to do a liver biopsy because I'm pretty sure based on everything I know, there's no
like a hep C, alcohol, or
I think the more common situation we deal with is if someone has something like autoimmune hepatitis or primary biliary cholangitis, and we just don't know what the etiology is. So versus drug-induced liver injury, like if I'm quite certain based on all the evidence that it's this diagnosis, then I'm not going to do a liver biopsy. If I'm not entertaining a separate diagnosis, there's no point in doing a liver biopsy. So I think that's one thing to keep in mind. Like there has to be at least two things in the differential. And then the second question is, does it affect clinical management right now? So, so a lot of times, this is particularly true in the inpatient setting. I'm not going to try to get a biopsy on someone in the inpatient setting unless I can make a decision in the inpatient setting that will change management. If it's something that can wait as an outpatient, then you don't need to do it now. Does that kind of answer your question?
It really does. And I think what I'm hearing from you is that if someone has, let's say, no exam findings, but has some thrombocytopenia, has imaging of like a cirrhotic appearing liver, you're comfortable saying, hey, likely it's cirrhosis. You get the elastography. If that was F3, F4, very confident in cirrhosis. But then the question becomes, what's driving the cirrhosis? And before answering that, in terms of like, how do you then classify these patients? Like, what should we be thinking about in terms of decompensation versus compensation, and what therapies that these patients need to be on if they're decompensated versus if they're not decompensated?
Right. So, well, let me get to the first point you made. So yeah, if, from a diagnosing cirrhosis standpoint, if I have a strong suspicion for nodular regenerative hyperplasia, meaning, they have a nodular liver, but they have like F0, F1 on both the FibroScan and MR elastography. So I'm just like, but they have no causes of liver disease that are apparent. I want to do a biopsy because I need to know if this person has a different diagnosis, and it could impact their causes. NRH, nodular regenerative hyperplasia, is associated with many autoimmune conditions and medications. So I might consider stopping one of their medications if it's associated with this disease. So yeah, so a lot of it is based on the clinical context. The second question you had is like, what is the impact of having compensated? Oh, how do I basically phenotype these patients? Yeah. Okay. So yeah, it's the fundamental thing when you have a one-liner, if they're compensated or decompensated. Decompensation means that they have a portal hypertension complication. So that includes hepatic encephalopathy, variceal hemorrhage, ascites. And so these are portal hypertensive related complications. So esophageal varices is not a portal hypertensive complication, of hemorrhage is. So I sort of considered those three things decompensations. There are some other things like, refractory ascites, hepatorenal syndrome, hepatopulmonary syndrome. They're all complications of portal hypertension. But if they have a complication of portal hypertension, they're decompensated. Otherwise, they're compensated. Now, there's something in the middle called compensated with clinically significant portal hypertension, which is going to confuse a lot of people. But it's the difference between someone who has cirrhosis with no splenomegaly or no esophageal varices versus someone who has splenomegaly, esophageal varices. They have clinically significant portal hypertension. So for me, it's like they have compensated cirrhosis with clinically significant portal hypertension, and decompensated cirrhosis. That's how I sort of think of it.
Okay, let's start with the first bucket, compensated cirrhosis. Should they be on any medications? Beyond, like, let's not talk about what's driving the cirrhosis. Like, let's take that out of the equation, just the fibrosis of the liver.
Yeah, so I sort of think of screening. So HCC surveillance, they need to have screening for liver cancer with an AFP and an abdominal ultrasound every 6 months. You need to think about risk reduction, so immunization. So they need to be immunized against hepatitis A and hepatitis B if they don't have hepatitis B and if they're not immunized. And then there has to be harm reduction. So thinking about things that can get patients in trouble in counseling. So those include eating raw shellfish, which increases your risk of Vibrio vulnificus. So I counsel patients on not eating raw shellfish, avoiding NSAIDs and Tylenol over 2 grams, which can lead to worsening liver disease, and avoiding herbs and supplements, which can be associated with drug-induced liver injury. So it's a combination of screening, screening for HCC and harm reduction, like I said, and then you have to make a decision about esophageal variceal screening. So the board answer to whether someone with cirrhosis needs an EGD is that give an EGD to everyone, but we've been moving away from doing that, and we have some non-invasive scores that we now use in guidelines to risk triage whether people are at risk of having esophageal varices. So that's the other screening consideration we want to consider.
So that's
a lot of information. So
no, that's what I'm going to summarize it. So all should get the annual ultrasound and AFP every
Biannual. Twice a
biannual. Okay, so biannual ultrasound and AFP for surveillance. All should have immunizations to Hep A, Hep B if they are not already serologically immune. And then harm reduction. Don't eat those shellfish, or be cautious. You're at risk of
raw shellfish.
Raw shellfish, of risk of Vibrio. And then the EGD is more plus minus. The hepatologist can decide if it's necessary.
Yeah, I think it's too complicated to discuss here. I think, and also I would say there's a lot of variation in practice, but I would just say that like we make certain, the board answer is everyone gets an EGD, but from a constraint standpoint, endoscopy scheduling standpoint, and a risk standpoint, I think I would sort of say that that just needs to be considered. The only other things I'll add is flu vaccination and pneumococcal vaccination and COVID vaccination.
Love it. We have 3 questions, 1 in person and 2 in the chat. Let's prioritize them before I continue our conversation. Maxwell is actually my incredible medical student, so I'm going to give the seat up to Maxwell. Please go in there and ask your question.
Hi, yeah, so my question I think deals with the third bucket that you had said with the decompensated cirrhosis. What is the clinical utility of a diagnostic paracentesis? I think you might have been getting there, but in terms of for people who have known cirrhosis and you have the ascites, what utility would the diagnostic sort of paracentesis be?
Yeah, that's a really good question. So there's 2 reasons to do a diagnostic paracentesis in a clinical setting. So that's to assess for infection, to assess they have peritonitis. So looking for that PMN count over 250 from the acidic fluid, which is the white count times the like neutrophil percent, and then sending a culture. The other point of getting a diagnostic tap is to assess what the cause of the ascites is, because believe it or not all ascites is caused by cirrhosis. So sometimes you have a complex clinical picture, and I think the standard of care though is even if it's cirrhosis is written 50 times in the chart, this is what the patient has. You'd be surprised that new ascites could be from a cancer. So we get what's called a SAG score, which is the serum to ascites albumin gradient and the total protein, and that can help us determine whether the ascites is portal hypertension related, not portal hypertension related, or exudative and could be secondary to a cancer or an infection.
Thank you.
And just to piggyback off that really quickly, Arpan, I've heard some people say any patient who comes to the hospital for any reason with known cirrhosis but has ascites, they should get a diagnostic para, because sometimes patients have no abdominal pain, has no fever, has no leukocytosis. What is your take on it? I'll tell you, as a generalist, I don't believe in that, but I would love to hear what your take is.
I know I would have to strongly disagree with you, unfortunately. So we now have like merging lots and lots of data showing that delaying a paracentesis for over 24 to 48 hours is associated with increased mortality. And we also know that all of these sort of conventional things that we look for in patients with any patient with an infection, like SIRS criteria, feeling unwell, are just not good indicators of whether someone has infection. We just don't have great clinical tools to assess it. And so it's basically playing a game of hot potato, right? So like if you're just sort of hoping that the patient doesn't have SBP when you're sort of, like when you're deciding not to do a paracentesis, kind of like how they say, I sort of compare it to my training, never let the sun set on a pleural effusion, right? So same sort of thing, never let the sun set on ascites and not being tapped. I think the problem is, and this gets to a lot of different other issues, but the capacity to do paracentesis is not always high. There may be people who are not trained in doing it, or we might rely on IR to do it. And I think there's a lot of structural reasons for that. Part of it is that ACGME is not mandated anymore that paracentesis is required. So lots of structural issues why we don't do paracentesis, but I do think it's required.
So I think you should trust Arpan over me for sure. But so you're saying anyone who comes to the hospital for any reason, and we see they're decompensated cirrhosis, they should get a diagnostic para. If they come in with knee pain for placement.
Yeah, you're fooled so many times, right? And I think, like, for instance, someone who comes in with a pneumonia and they're septic, obviously it's from the pneumonia, but you never know that. I'm just giving an example because I've seen it, not just I'm saying like anchoring you to one thing, but someone had an infection, became encephalopathic, aspirated. And so what you're seeing is the pneumonia.
Yes.
But actually there's like a whole deeper clinical context.
You've converted me, Arpan. Let's move on to our questions from the audience. So Boris, who's actually a great friend of mine. Boris, are you able, man, we would love to hear your voice. He's coming to us from Europe. He's an ID doctor. And he asked the question, how do you interpret an elevated GGT without an elevation in the alk phos?
That, that happens sometimes. It doesn't happen very often. Honestly, like that sort of false positive for GGT, I honestly mostly ignore it, to be perfectly honest. Like if there's elevated GGTs, because in and of itself is not, without an alk phos, because in and of itself is not clinically meaningful. Sometimes we do see an elevated GGT in people who drink. So that was actually one of the like sort of early telltales of someone who had recent alcohol use, is that we would see a high GGT and a high MCV. So I think like there used to be these sort of indirect tools to catch people drinking, if you will. But I don't actually view that as, to be honest, very clinically meaningful when someone has an elevated GGT but not alk phos. But that's a really good question.
The next question, Arpan, which I think is right up your alley of expertise, is it safe to start naltrexone for alcohol use disorder in a patient with cirrhosis?
So the answer, so this is a controversial question because there was a black box warning for naltrexone that actually got lifted 2 years ago, saying that you can't use it in liver disease. And it was actually based on case report data and just actually a lot of bad information. And so I think the hepatology community was a little bit stung by that and wants to kind of get more prospective data. That all being said, there's a lot of good retrospective data and good modeling studies showing that naltrexone is safe in patients with Child-Pugh A cirrhosis and Child-Pugh B. There's a randomized control trial that was presented at last year's EASL meeting, which is the European meeting, that actually showed that it was safe in Child-Pugh C. It has not been published yet, but for me in my practice, I use it in my patients with cirrhosis up to Child-Pugh B.
I have one last question for you before we summarize and wrap up. Ammonia levels. When should we be sending the ammonia levels?
Never. There's no clinically meaningful reason to send ammonia levels in patients with cirrhosis. It doesn't help with diagnosing them. It doesn't help with looking for treatment response. And it might actually end up leading to inappropriate care. So more common thing we see is someone who has a high ammonia for X, Y, and Z reason, because it's such the test is so sensitive to how you handle it after you draw it. So it has such inaccurate readings. But we've seen people get started on lactulose who were like totally fine and they just had a high ammonia, and then they're just, going to the bathroom all the time at home. So it can lead to a lot of inappropriate care. The only time I ever assess an ammonia is as a prognostic tool for patients with acute liver failure to assess whether they are at risk of a high intracranial pressure, meaning or high herniation. So that's the only reason I ever send an ammonia, and it's arterial ammonia on ice, but never for patients with cirrhosis.
We can talk for hours and hours and hours. And I will say, like, that topic of acute liver failure versus cirrhosis and its implications is such an important point. But I just want to summarize as you're thinking about your takeaways for today's talk and what you want each audience member to walk away with, except for the points that you made earlier, I'm just going to read what Dr. Morietti said. He said, more dangerous than naltrexone is continued drinking. As my friend says, if there is still a sliver of liver, use naltrexone.
Yeah.
That's really powerful. Thank you, Dr. Morietti. So what are your takeaways? And now I'm going to think about my takeaways.
My takeaways, I think that, I will kind of go back to the fact there's a shortage of hepatologists and more liver disease. Use this as your friends in consultation. Like we're, especially in health systems at the VA, we're following up on these patients. Involve us. Let's have some more bidirectional education about these patients, and don't feel afraid of consulting a specialist for these patients because they're complex. And I do think that getting more familiar with these phenotypes, right? Like compensated, decompensated, clinically significant.
You're not supposed to take my pearl away.
F1 to F4, like really, really deeply phenotyping your patients is really critical because it gives you a sense of what the priorities are for clinical management.
I love that so much. And that's really was my takeaway too, of like compensated versus compensated with significant portal hypertension versus decompensated, thinking of hepatic encephalopathy, not just varices, but variceal bleed, and of course, ascites. And another really powerful takeaway is that like have the lowest of low thresholds to do that diagnostic para, because if you delay the diagnosis of SBP, it can have serious consequences, including death in your patients. And I think the last takeaway I have is really I never thought about elastography as such a powerful tool to even like motivate your patient, because the earlier you're able to show fibrosis, the sooner you're able to reverse that. And the advent in all these medications to lower obesity, which I wonder if it's the #1 cause in the US right now of cirrhosis, like if it's overtaken Hep C and alcohol.
Yeah, well, alcohol and MASLD are like neck and neck, and they're really our biggest threats right now.
All right, we got to have some cool sign out. What should our sign out be for these sessions?
What do you think, Reza?
Well, I'll say this. I thank you so much for joining me today. You are just so full of knowledge. And I just want the audience to know too that he's my friend. So I got to call Arpan at 8 p.m. and curbside him. But if you get to know him well, you will get that privilege too. So this is my sign out. Study today so you're better tomorrow than you were yesterday.